want to sincerely thank Dartmouth Hitchcock for their tremendous and ongoing work on payment reform and healthcare issues of every kind and sort. Their commitment to healthcare in New Hampshire is astounding, and we appreciate their contributing to this day and this seminar through lunch, et cetera, and helping bring Cynthia Mann here. So here from Dartmouth is the former U.S. Attorney and current Chief Legal Officer and General Counsel of Dartmouth Hitchcock, John Kakavas. Thank you.
Thanks, Liz. Thank you, everybody. Thank you very much. On behalf of Dartmouth Hitchcock, welcome. Lucy asked me to offer a few comments about why Dartmouth Hitchcock is sponsoring this lunch and why we want to participate in this symposium. And the simple answer to that question is because Lucy asked. I have been a big fan of Lucy since our days in the Attorney General's office together, and I learned long ago that she is a force of nature to whom you do not say no. And I, like probably many of you in this room, don't want to test that proposition. So you're eating out of boxes on Dartmouth Hitchcock today. But an equally important reason why Dartmouth Hitchcock wants to participate in a symposium on innovations in healthcare policy and law is because as New Hampshire's only academic medical center, we are committed to innovation in the delivery of healthcare services. And one vehicle for that innovation, I'm pleased to report, we just opened our Williamson Translational Research Building on our main campus in Lebanon. And that is a vehicle for pushing out advancements in science and research to the front lines of clinical practice and patient care. And we're really excited about the advancements that the Williamson will contribute to and other innovations that Dartmouth Hitchcock is involved in. And now it's my pleasure to ask Commissioner Nick Toumpas of the New Hampshire Department of Health and Human Services to come and introduce our luncheon speaker, Cynthia Mann, and I know we're all looking very much forward to Cindy's comments. Commissioner Toumpas has been in this role presiding over New Hampshire's largest government agency since 2008, during which time he has overseen some of the most fundamental and progressive advancements improving the lives of people and communities in New Hampshire. So, Nick, please come on up.
Thank you, everyone. It's a pleasure to be here, and I want to echo the comment that John talked about Lucy being a force of nature. So it is with great pleasure that I welcome Cynthia Mann back to New Hampshire. When Cynthia Mann recently left her post as the CMS Deputy Administrator and Director for the Center for Medicare and Medicaid Services, as well as the CHIP program in Washington to join the Manat firm, all of us in here in New Hampshire felt a loss. Cindy has been a trusted, creative, open, and instrumental partner to Medicaid directors across the country, and clearly here to us in the state of New Hampshire. At Health and Human Services, we work to implement a Medicaid program in a way that really serves all of our clients in the most efficient and effective way as we can, and try to be innovative. We pride ourselves in meeting the needs of the most vulnerable citizens. We simply can't do the work that we do without all the folks that are sitting in this room today or the organizations you represent. So it's truly a partnership here, and that partnership is extended with the work that Cynthia Mann had done over the years with us from CMS. She's been innovative when we really needed some solutions. She's been firm when we asked for too much, and we often did. And we has always been accessible either over the phone or to travel down to Baltimore or Washington. Her leadership and her guidance was never more important than over the past few years as we embarked on a number of significant innovations here in the state, specifically around transforming our Medicaid program to a Medicaid managed care program, to standing up the New Hampshire Health Protection Program, which as of yesterday, we are now over 43,000 people who now are newly eligible and now have an opportunity for greater health and opportunity to improve their lives moving forward. Her support and innovative leadership was never more appreciated. In addition to that, she has been a guiding light for us, really, in terms of moving the program to the premium assistance program that we began the enrollment into that on November 1st. Cindy has always been passionate and an advocate for beneficiaries while keeping a firm eye on taxpayer resources. Over the years, she's been very responsive to matters here in New Hampshire. She has family roots here in Manchester and has always paid close attention to our steps forward and at times some of our missteps over the years, offering advice and input on complex issues that we deal with. She's changed the lives of children and families through her work prior to going to CMS as the director for the Center for Children and Families and professor at Georgetown University Health and Policy Institute. A few of us will remember back a number of years ago where Cindy was very instrumental in providing some guidance to the state regarding a 1115 global waiver that was being contemplated here in the state. As commissioner for the department for the past 8 years, I can say with complete admiration that her dedication to public service is remarkable and deeply appreciated. If one were to go across the state and talk to some of these 43,000 people, or across the country and talk to the millions of people that now have who Cindy Mann is, they will not know who she is. We do. But again, in this state, there are 170,000 people that are on the Medicaid program and millions across the country that have the potential for greater health and peace of mind today and in the future because of the work and the leadership of Cindy Mann. So on behalf of all of us here in New Hampshire, I want to welcome Cindy back to the state, and I can only say thank you. Cindy?
I can do a tap dance first. One of the things I'm really good at, having New Hampshire roots, is singing the UNH fight song. So we'll see if it comes to that. It is. Okay, we'll just walk through them. Okay, that's fine. That's fine. Everybody can look at their packets. It is really great to be here, and I do have very strong family New Hampshire roots and feel very connected to the Granite State. I want to thank Nick for his very kind words. It really is a pleasure to come back and meet and speak with some of the state administrators who I work so closely with, and it wasn't always easy, and it wasn't always a yes, but I think it was always with an idea as we worked together that we were trying to move forward together to make the healthcare system generally better for people and specifically to strengthen the Medicaid program. And I think when you work on those common purposes and you can be honest about that, the other differences, they come and they go, but they end up falling by the wayside because we all have a common objective and move forward. So I really appreciate all the work that Nick has done and his team here. I wanted to thank Lucy, who will now, I think, forever be known as the force of nature. That is such a perfect term for Lucy. She has been really my go-to person in recent months and years as the state was moving forward with its Medicaid expansion and with the premium assistance waiver as well. And while they're not here, I do want to thank both the governor and the senator for their kind words and their acknowledgement and really appreciate their leadership as we've gotten to the place where we are right now. Let me also call out two additional people. My colleague, Deborah Backrack, who you saw a minute ago. She and I are now partners in crime at Manad, and a lot of what I'm going to go through with you in the slides today are things that she's worked on and we've worked on together, so I want to share credit. I also want to call out a special friend of mine, Elizabeth Kenny, who was my first research assistant, research analyst, at the Center for Children and Families at Georgetown, and health problems took her away, but landed her here in the state of New Hampshire, and she's doing great, and she is moving healthcare policy forward in all sorts of positive ways. So hats off to my friend Elizabeth, and it's great to see you again. So we'll go to the paper, right? Or you could have the after lunch doze and look like you're looking at the paper. See how it goes. I'm the doze bridge, but I think of, as I thought about the agenda today, I'm really the bridge, I think, a little bit between what the law is and how it's changed over the period of time, with a particular focus on the Medicaid program, and really then turning the corner to the afternoon discussion, which is, what do we do to make sure that the health care that we're delivering to people is high quality, efficient, the right health care, the right time, the right place, and delivered in a way that's very person-centered. So, and hopefully we'll have time for lots of discussion and back and forth, so we can move forward on that. So I'm going to start off by talking about what I called here the new Medicaid. And for those of you who've lived through the evolution of Medicaid over the last 50 years, 40 years, 30 years, or even just the last 5 years, you know how much it has changed. Other people, though, are not necessarily entrenched in the Medicaid details. And while they know that there was a Supreme Court case that had something to do with Medicaid, and while they know that now the Medicaid expansion is a state option, and while they know, if they live in New Hampshire, that New Hampshire has moved forward with that option, some of the ways in which Medicaid has really fundamentally changed, I think, is not necessarily clear to everybody. And it seems to me important to go through that, not just because it's nice history, but because it informs us about where we are today and what, more importantly, our agenda is as we go forward. So I'm going to talk about the new Medicaid and then talk about two areas of focus that flow from that, which is how to solidify the coverage gains. We can't, I think, take too lightly the challenge before us to make sure that we in fact get to the kind of near universal coverage that is now the promise of the state of for the state of New Hampshire, and also what's next on the agenda in terms of delivery system reform. And as the panel before talked about, those two are very interrelated. Right? If you think back about the Affordable Care Act, it was really not just about getting people covered, it was about getting people covered so that we could improve care, improve health, and in that way also begin to think about bringing down that cost curve. So if you look at the new Medicaid, if you're following along, I'm on the fourth slide. Let me talk a little bit about some of the key turning points in Medicaid history. And I do that again not to just jaunt through memory lane, but really to be able to underscore the fundamental changes in Medicaid, but also to lay bare why we have sometimes a big debate about Medicaid. Oh, is it a welfare program? Is it not a welfare program? Is it this? Is it that? Well, some of the ways in which it gets described aren't inaccurate as it existed 5 years ago, 10 years ago, maybe 40 years ago. But I think are largely not the story today. So let's look at what the trajectory has been. Medicaid started, I think as you all know, in 1965. We just celebrated the 50th anniversary of Medicaid and Medicare. And it was started as an adjunct to welfare. At that time, we had the AFDC program, Aids to Families with Dependent Children. We had the ABD program, Aid to Blind and Disabled People, which was the precursor for SSI. AFDC was the precursor for the TANF program. So we had those two welfare programs helping the elderly and the disabled and helping families with children. And if you applied for those programs, and if you were able to get through the process, and if you were found eligible, at the end of that process, you got a little, I would say a card, but you didn't get a card. It usually was a piece of paper that said, oh, and by the way, you get health care benefits. It was an adjunct to welfare. And it's significant to remember that because in terms of thinking of where we are now, because both the eligibility for Medicaid, but also the way in which you actually access that coverage was through the welfare system. And that's the way it was, and that's the way it was in 1965. And so it remained a pretty small program with pretty even pitch, as you might imagine, because welfare wasn't really rising in any significant ways during that period of time. Until what happened is in the mid-1980s, through the rest of the 1980s, early 1990s, Congress began to enact changes in the Medicaid program to solve problems. And that's really been the history of the Medicaid program in terms of federal legislation. It's like a problem would pop up and people would say, let's look to the Medicaid program and see what we can do about it. The problem that Congress was focusing on in the mid and late 80s was infant mortality, low birth weight babies, poor health care for children. And so what they did during that period of time is enact several different pieces of legislation, really a successive long list of legislation. That'll, thank you. Yeah. And significantly, what it did for the first time in Medicaid's history, in a significant way anyway, is it delinked eligibility for Medicaid from welfare. Thanks so much. From welfare for those populations, for children and for pregnant women. So you still went through the welfare application process. You would still get your Medicaid as a function of getting your welfare benefits. But in addition, pregnant women were now eligible, regardless of their eligibility, for cash assistance. And so were children, first for very young children, and then gradually, through a change that was enacted in the late 1980s, cohorts of children by age were brought into eligibility in the Medicaid program without regard to their eligibility for cash assistance, vastly expanding the group of people that were eligible for Medicaid, but also breaking that historic link between eligibility for cash assistance and Medicaid. The next thing that happened was that in 1996, AFDC was repealed. The Aid to Families with Dependent Children program was repealed, and it was replaced by the TANF block grant. And with the TANF block grant ended the entitlement to welfare. There was an entitlement to AFDC, albeit at very low income levels, but if you met the eligibility requirements, you were entitled to be in the program. TANF gave a lot of flexibility to states. No longer was there a particular entitlement. States could design programs as they chose to design programs. And the expectation was, for a variety of reasons, that the number of people receiving cash assistance would be reduced. And so remember the link to Medicaid. If the number of cash assistance people were going to be reduced, then it looked like people were no longer going to be able to access their Medicaid benefits, or the Medicaid benefits that they might otherwise have had. Well, think back also in 1996, for those of you who can think back to 1996, it was not a time where there was a lot of favor for poor women. It was not a time where Medicaid was not in very much the trenches, right? It was the same legislation where TANF got passed, where there was an effort to block grant the Medicaid program, and but for a veto from President Clinton, it would have been block granted. So we were not approaching a time of, let's really think about how to expand Medicaid and how to get more health care to low-income women. But there was a recognition of the importance of health care benefits to low-income women. And much as there was an interest in moving the welfare system in a new direction, there ended up being a consensus in the Congress that said, but we shouldn't be taking away health care. And so we had, curiously during that time, another major change in the Medicaid program, which was a delinking of Medicaid eligibility for the parents of children. So we've delinked for kids, we've delinked for pregnant women, and we delinked for parents of dependent children, so that they could qualify, usually at very low income levels, but regardless of whether they were receiving welfare. Okay? So low income levels, but still not conditioned on receiving public assistance. The next milestone that I created that I put on this chart, I never really created, was the establishment of the CHIP program. Now, CHIP didn't necessarily require any changes in Medicaid eligibility, but it made a big change in the world of Medicaid, and here's how. What CHIP did is it put new money on the table, a higher match rate, to encourage states to even further expand coverage for children. And they could do so either by extending the Medicaid program to kids with higher incomes, or they could establish a separate CHIP program, child health insurance program, as you did in New Hampshire, and sort of a public-private enterprise, or you could do a combination of both. Right? A little Medicaid expansion, a little separate state program. And states have done all of the above and have changed their trajectory over a period of time. So that was great in the sense that it really got Medicaid eligibility for health coverage, whether through Medicaid or through CHIP, at higher income levels, helping a new group of children whose parents couldn't still afford the private insurance that was offered at the workplace or didn't have an offer of private insurance at the workplace. But why I put it on this chart is that what CHIP ended up doing, not by federal legislation, but really by state action and by community energy, was it took the welfare department out of Medicaid. And I don't mean that in a disparaging way. The welfare department does many great things. But what happened during CHIP time is that everybody got excited not just about making the kids eligible, but getting them enrolled. They thought, it's not enough to just get people eligible. We really want to increase participation rates. And so what CHIP triggered is a change in the way states were operating their Medicaid programs, their CHIP programs and their Medicaid programs, at least for children and pregnant women. Sometimes not for the whole population and not also for the parents, but for the kids. And there was almost a competition across the country to say, we can get those kids enrolled. And what that did is it simplified the application process. So whereas the 1980s legislation delinked Medicaid from welfare for kids, the process was still pretty much the same. You still had to go to the welfare office. You still had to have a face-to-face interview. You still had to fill out a very long application. You still had to bring a wheelbarrow full of documents in order to prove your eligibility. And then you could get your benefits if you got through all of that. But as a result of the modernization that went on in the program, at least for kids, following the enactment of CHIP, the process became very different. Simplified application, much more reliance on data-based verification, simplified renewals. All of these were practices that states began to develop and that started to spread across the nation. And then, of course, we had the Affordable Care Act. And the Affordable Care Act, again, as viewed through the lens of Medicaid, is often seen mostly as the expansion for the adults left out of coverage, and to make sure that they would have access to coverage. But the Affordable Care Act did much more than that from the lens of the Medicaid program. It really confirmed Medicaid's place, not as an adjunct to welfare, but as a standalone health insurance program. And it firmly took the Medicaid application processes that had been developed over the years and switch them from ones that had been grounded mostly in welfare rules and welfare practices, and grounded them in healthcare marketplace rules and practices. And that was very significant, as significant, I would argue, as what went on in terms of the Medicaid expansion. So here was the vision. And we talked about the comment earlier today. I was thinking, yeah, this chart looks great, but that's like, there's a lot of messiness underneath that, right? In terms of all the things we were talking about in silver and, tiers and different plans and so forth. But step back for a minute and appreciate the beauty of the design here. And then we'll get to the underbelly. But what the Affordable Care Act did is it left in place the three major programs or the two major programs that were providing coverage to people, Medicaid and the Children's Health Insurance Program, and then it created the marketplaces with the tax subsidies and the cost sharing reductions. And so that's a confusing array of programs just from the start, right? But what it did is it took steps in the law to say, we got to make this work as a continuum of coverage. It's got to be a coordinated system of coverage, even though we're relying on different programs. And so in its perfection, this is what it ought to look like. Meaning you have subsidized coverage available to adults and to children, regardless of family type. Doesn't matter if you're a childless adult, if you're, this is for non-elderly adults, but it doesn't matter if you're taking care of a dependent child or your child grew up, your child had its 18th birthday yesterday, or it's going to have its 18th birthday 5 years from now. Adults and children, regardless of family circumstances, have access to affordable coverage, subsidized coverage if their income is between 0 and 400% of poverty. And the way you access that coverage and those subsidies will depend on whether you're an adult, whether you're a child, and what your income level is. But it should blend together because the law, and it's not best practices. CHIP was best practices. ACA, I say to a room full of legal beagles, is the law which says now you have to have certain parameters in place, certain conditions and guidelines for how the system is put together that will make it look and feel to the consumer like a continuum of coverage. It will address the churning issues. We will still have some cliff issues that we talked about before, which is why those colors aren't completely blended. But we no longer have the cliff of you end coverage over here, you're not eligible for anything, or maybe you're eligible, good luck to you, we hope you find it, right? And so here are some of the key features of what the Affordable Care Act requires that make that continuum of coverage work, at least in the law, if not fully on paper. And I think it's working fully on, on the ground in many communities around the country. So, one, Medicaid rules for eligibility change. I'm not talking about the expansion. I'm not talking about whether your income went up to 138% of poverty or it stayed at the old income level. The way in which eligibility is determined in the Medicaid program, the rules used to be based since 1965 on the welfare rules. Even after AFDC got repealed, the Medicaid rules were still based on the AFDC rules, right? You had a net income deduction, you had a complicated way of figuring out eligibility, a different way of figuring out family size. Well, you can't make that continuum work if you have one way to figure out income for Medicaid, one way to figure out income for CHIP, and one way to figure out income for the marketplace subsidies. And so what happened in the Affordable Care Act is that it completely replaced, for non-disabled, non-elderly adults and children, completely replaced the methodology for determining income. And instead of being attached to the welfare rules, it now is attached to the marketplace rules. So that way income is counted is pretty much the same for Medicaid and CHIP as it is for the marketplace. As you can imagine, it would need to be in order to avoid overlaps and gaps in coverage. Right? So big change, lots of work on every state's part. Didn't matter whether you expanded eligibility or didn't expand eligibility. Big changes in how the Medicaid program operated. Similarly, no wrong door philosophy. One application for the 3 programs. So you didn't have to figure out, am I Medicaid? Is my child CHIP? Am I marketplace? I'm not sure. One application, you go through the process, and the process is supposed to be, with decision trees, electronically putting you into the right place at the right moment, and pop out comes for the determination of which program you are eligible for. Sometimes it's a mixed result for a particular family. Child might be eligible for CHIP, parent might be eligible for marketplace. But the point is, one application for the family will get everybody in the family who's eligible enrolled in the appropriate program. Is the design and, in fact, the requirements of the law. Certain other things that ease the process of application that we saw have such a big effect in the children's programs became not just best practices, but the law of the land. So, for instance, no more face-to-face interviews. Most states had gotten rid of them, but not all states had gotten rid of them for the Medicaid program. You had to have various ways to apply: in person, by mail, by phone, and also online. And we had seen states experiment with the Medicaid population of online applications and seen it explode as a way in which people found it very easy to apply when they were, late at night and they couldn't go to an office, and they can sit down at their computer and they can apply online, either by themselves or with the help of a navigator or a friend. Very big change. That wheelbarrow full of documents that was the calling card of your Medicaid application or your welfare application, throw that wheelbarrow away, replace it with a data-driven verification and renewal system. And this is really one of the most significant things that go on, that the changes in the Medicaid program. The same verification and eligibility rules apply to the marketplace, apply to Medicaid, and apply to CHIP. So you don't ask for 6 weeks of pay stubs. You look at your data system and you look at what the income was, and you go to paper only if there's an inconsistency or something that you have to do some further follow-up with. Same rule goes for renewals. Very important to keep an eye on renewals, because we have seen throughout the history of Medicaid and CHIP, and we'll see it in the marketplace as well, is we will lose people that we work hard to enroll. We'll lose them at renewals unless we apply the same kinds of simplification and modernization efforts in the renewal aspect of the program. So the law was very clear on what the expectations were and what the bottom lines are. States could raise the bar a bit, but minimum standards apply. And to make that glue, to make it really work, there were also rules on information technology systems, IT systems, shared eligibility systems between Medicaid and the marketplace and the CHIP program, or at least systems that talk to each other, because obviously you're not going to share it, particularly if you're in a state where you're relying on healthcare.gov. And part of the effort to make it all real was the federal government provided 90% share of funding from the federal government for these IT eligibility and enrollment improvements in the Medicaid program. So, as a result of all of this, we have a very different Medicaid program. It is the new Medicaid program, and it's important that we understand its role in serving low-income populations, but in the healthcare marketplace writ large. It is now the single largest source of health insurance in the country. More people get their coverage through ESI, through employer-sponsored insurance, but in terms of a single program and source of health insurance, Medicaid is now larger than Medicare, both in terms of expenditures and in terms of numbers of people covered. That is a very important realization, not just for those who toil every day on trying to make the Medicaid program stronger, but for the rest of us who work in our healthcare system to understand the market influence, the importance of the Medicaid program, and to no longer think about it as, what about Medicaid? It's this other safety net program over here. It is too important a source of coverage to ignore, and it has an incredibly important role to play in terms of driving better care and better health. So New Hampshire's always marches to a little bit of a different drummer. So your trajectory on Medicaid is a little bit different than the nation as a whole in terms of the reliance on the Medicaid program. This is pre-ACA, so I'm comparing U.S. and New Hampshire pre-ACA 2013. And you'll see the reliance on Medicaid is less than the U.S. average, not because you hadn't expanded by then, only a few states had expanded before the ACA, but really because you have a much stronger employer-sponsored insurance system than the nation as a whole. And that's a real strength for New Hampshire in terms of thinking about how to get to near universal coverage. You had lower uninsured rates and you had lower reliance on Medicaid, but still had 11% of your population be uninsured. So it'll still be a major player in New Hampshire, but because of the strength of ESI, somewhat less probably even as you get fully ramped up in your expansion than the nation as a whole. So that's a little bit of the background and the history. Now let's talk to efforts to move forward. And the two areas that I want to focus on are solidifying those coverage gains and thinking about delivery system reform. So what we have seen, and the panel before me mentioned many of these things, and we've actually heard about them all throughout the morning, which is there were a lot of projections. Right? The world is going to come to an end, or it'll all be wonderful and perfect. Okay? It's not been either of those, frankly, having lived through healthcare.gov. But what we have seen in real life, moving from projections, are the following: very robust enrollment. Robust enrollment in the marketplace, robust enrollment in the Medicaid program. We have seen a historic drop in the uninsurance rates. A drop that I think only a few of us would ever imagine we'd see in our lifetime. And we see that most starkly, of course, in the states that have expanded Medicaid. We see also with that, not surprisingly, but reassuringly, greater access to primary care. Anyone who's heard Governor Schneider talk about the growth of Medicaid in his state, so he's the governor in Michigan, Republican governor, Republican legislature, enacted the Medicaid expansion, and Enrollment exceeded projections as it has in other states, and I'm going to get to that in a minute. And when challenged about that, Governor Snyder says, yes, and let me tell you all the people that got primary care coverage. Let me tell you the number of women who got mammograms. Let me tell you about the kinds of cancer screenings we've had in the state of Michigan as a result of that. We have seen access to primary care and to preventive care increase. And what we've seen go down is savings, is uncompensated care, and therefore some of the cost shifting that happens as a result of uncompensated care, as well as the pressures on the hospitals that provide it. And as Deborah talked about earlier, economic benefits to states. And I'm not talking just about, or I'm not talking actually at all in this instance, about potential ripple effects of having additional federal dollars in the state, and what does that do in terms of economic benefits. I'm just talking about hardcore, what's happened to state budgets, what's happened to local and state expenditures, and what was projected, but what has been in fact verified, is that states have seen real significant savings in their state budgets because either items that they have used state-only dollars for have now been able to qualify for a federal match because they've gotten coverage for the individuals using those services. That's true at the state level. It's true at the local level as well, where a lot of the responsibilities for some of the indigent care resided. We've also seen that some categories of services, some categories of people who used to get the regular match are now qualifying legally for the enhanced match because of the way in which the eligibility categories might have changed in the state. So we're seeing also state benefits around that. And also some states have relied on hospital provider assessments or other kinds of provider assessments, and even when they don't change the law, if the base of those assessments has expanded, then we're seeing more revenues come into the state. So we've seen significant economic benefits. It's early in New Hampshire, though we got some more late-breaking results this morning. Thank you, Nick. But we've seen that same kind of strong results in terms of the uninsurance rate dropping in New Hampshire, decline of 32% in a year. It's really remarkable. And with that, we've seen a decline reported by the Hospital Association here in New Hampshire by 28% of uncompensated care. Again, that's 1 year. New Hampshire implemented, as you know, later than some other states, and so we are going to continue to see those benefits accrue to New Hampshire and its residents. But a curious thing happens about those enrollment gains, which is that while we see, whether it's healthcare.gov or it's the marketplace at the state level, constantly scrutinized to see whether or not it's getting the enrollment it projected, whether it's projecting enrollments too low, whether it's been successful in enrolling people. We see a little bit of the opposite of that sometimes, Governor Snyder aside, sometimes when it comes to Medicaid. So when Medicaid has largely been more successful than many of the states projected it would be in terms of bringing in new coverage and getting more people uninsured. So the gains have been terrific, strong across the country in terms of states that have expanded in particular. But instead of celebrating or saying, ooh, maybe that broken system is actually working really well, and people are getting enrolled and covered, we see a lot of criticisms. And you could say that the criticisms are based on people don't like the Medicaid program, they never really wanted the Medicaid program to be there. They could be also based on concerns about budget implications. So just to think about the budget implications, which is certainly a legitimate concern that we all share as we think about financing for health care coverage. Of course, in the first few years, if projections are off, it is 100% federally funded for the first 3 years of 2014, 2015, 2016. Never goes below 90%. It gradually declines starting in 2017, but never goes below 90%. So most of the costs of having higher than projected enrollment is borne by the federal government. There may be some out-year projections, but we've also, harken back to what we were just talking about a minute ago, we've also seen significant state savings in their budgets. And we see enormous benefits to the healthy workforce, to a healthy population, to the reduction in uncompensated care as we get more people covered. So I think part of the challenge for all of us is to turn around that discussion and again be celebrating when we are so successfully contributing to the reductions in uninsurance, which is the chart on the left, is the nation as a whole. And I just remind us again by the celebration that we all had and all shared, and New Hampshire was certainly among those states, around our successes in enrolling children. Children in the Medicaid programs, mostly Medicaid and the CHIP program, the lion's share of the coverages in Medicaid. We have been increasing participation rates in the Medicaid and CHIP programs. What I mean by that is the percentage of eligible kids who are actually enrolled in coverage. We have been increasing those participation rates every year since 1997 when CHIP first got established. And we are now at a point where 19 states, including New Hampshire, have a 90% or higher participation rate. And that's seen as a good thing, not a bad thing. That's the point of the program. Let's get people covered and then move on to delivery system and payment reform and assuring that they get good quality care in the most effective and efficient way. So let's turn to state budgets, which always is the looming issue in the Medicaid program, right? Okay, maybe it's a good idea, but isn't it eating up my budget? It is a very large share of state budgets. So a couple of numbers here. You often see that Medicaid is the largest item in state budgets. That's actually true generally, but only when you count the federal dollars coming in as well as the state dollars being spent. Now, if you look at the total expenditure for Medicaid, state and federal dollars, and look at total expenditures in a state budget, Medicaid is about 26% for the nation as a whole. These are National Association of State Budget Office data. But the federal dollars that come into Medicaid to the state government don't compete against education. Right? They don't compete against housing or community development or other priorities of state government. In fact, they help states by lightening their state dollar load on health care. They actually help a state probably free up some state dollars to attend to those other needs. So I think the more salient point, at least when you're looking at competing priorities at the state budget, is to look at state dollars and take the federal dollars out of both the numerator and the denominator in state budgets. It is not to say that Medicaid isn't still a very large share of state budgets. It is. It's about a fifth of state budgets, 20%. No longer the largest expenditure in state budgets, but certainly a large expenditure. And so that's in part why we constantly have debates and discussions about the Medicaid program in state capitals all around the country, not just because state capitals are the bastions of health policy debates, but because it's a big budget impact. And so now we have to look under the hood a little bit. Where are those costs in the Medicaid program? And is the expansion going to push those costs significantly higher? What's driving those costs? And what can we do, if anything, to be able to affect those costs in a positive way? Well, one thing is if you look at the Medicaid program, and no one who's been through the recent 10-year history of Medicaid in New Hampshire would be surprised to hear this fact, which is it's not increases in per enrollee spending that is driving up Medicaid spending. It is that we're covering more people. Okay? That is actually in contrast to what's going on in private insurance and in the Medicare program. In private insurance, we're covering fewer people. If you look over, the period of time here, 1997 to 2013, right? We're covering fewer people, but the cost has risen because the per enrollee costs, largely because of per enrollee costs. Medicare has had more enrollment growth in private insurance during this period of time, but not nearly as much as Medicaid, and their per enrollee costs in the Medicare program has grown by 14%. Medicaid, it's grown by 6%. That still could be, particularly in a time of an economic downturn, more than your growth in your state revenues, right? So you still have the clash of interests and that tension that goes on about the Medicaid program. But it is because we're covering more people and because health care is expensive generally, and because our tax and and other sources of revenues, particularly in times of downturn, but sometimes just in moderate times, don't keep up with the rising cost of health care. So it's important to keep that in mind, not to say that Medicaid isn't a budget issue that we all need to think about, but because it's a wildly out of control spending program, but because it's doing its job covering a lot of people, and health care is pretty expensive. So let's dig down a little bit further. If you look at the beneficiaries in New Hampshire, and this looks the same across the country, remarkably the same across the country, we have a minority of our beneficiaries account for a majority of our spending. So not surprisingly, people who are disabled and people who are elderly are the smaller numbers of beneficiaries in the program, but they account for 19% of the beneficiaries in our Medicaid program. This is 2011 data, but again, it's pretty consistent by year and by state. But they account for 67, more than 2/3 of all the costs in the program. And if you look at the banner up above, you see that when you start to drill down, it's even more skewed. 5% of the beneficiaries in the Medicaid program account for 56% of our expenditures. So if we want to think about how to address costs, and I would argue also better care, because those are the populations that have high medical needs, complex medical needs, and ones that are being served largely by a very fragmented healthcare delivery system. And that's not, of course, unique to New Hampshire. But if we want to save dollars, it is not thinking about how did we enroll an extra 10% of the newly eligible, and should we not be celebrating that? But how are we going to deliver better care to people, and particularly high-cost people, in better ways? And through doing that, hopefully also affect the cost curve. It's not easy. So let's talk about delivery system reform, which is my precursor to the afternoon's discussion. There's a dizzying array of things we all ought to be doing and knowing about and figuring out and deciding. And I think all of us walk around a little bit with, what do they know that I don't know, right, about delivery system reform, right? I was just having a conversation, I won't say with whom, but somebody from New Hampshire, and said, like, what do you think population health is, and what can we do to make it work? We're all still figuring it out, right? When people talk about value-based purchasing, and I'm among them, you get 6 people in the room to say, what do you mean by value-based purchasing? Lots of different discussions, lots of different theories about what it is and what will work. That being said, there is change aplenty going on in our healthcare system, and it is the time to jump aboard and to experiment and to see what works. Accountable care, organizations, shared savings, bundled payments, value-based purchasing, all of these are features in one or another systems, both commercial as well as applicable in the Medicaid program. My point here is that Medicaid, as the largest health insurer in the nation, has to be part of the picture. And more than that, it actually has a role in leading the movement to better delivery system and payment reform. And it can do so through many different ways, making sure we have access first. Well, I'd back up and say first, making sure we really have the coverage, right, that we've promised people, right, so that we really want to get to 90+ participation rate, not just for our kids, but for our adults in the Medicaid program as well. Because when we have that coverage in place, when we have that continuity of coverage, because the marketplace coordination works well, then we can really begin to think about person-centered care in a real way. Somebody's on and off of coverage, whether they're on and off inside the Medicaid program because of renewal problems, or whether they're on and off because they're flipping between Medicaid and the marketplace and Medicaid, is going to be one of the biggest hurdles to move forward in terms of real delivery system reform and real cost control, frankly. So making sure that people have access to care and that the care is patient-centered, thinking about whatever it may mean to you, we can talk about this, value-based purchasing, focusing, as the data really point to, the needs of high-cost enrollees, the populations. When Medicaid started doing managed care, it enrolled everybody but the high-cost, high-needs people. too hard. Plans didn't want them. States were rightly concerned about risks to those populations of enrolling them in plans that may not be prepared to care for them. Doesn't have to be that you enroll anyone in managed care plans, but it does mean if we're going to improve care and we're going to think about costs, we really have to think about where the high needs are, and making sure we've got alignment across the marketplace, again, both for continuity of coverage, but also alignment in our methods for moving delivery system and payment reform. If we are, as the slogan goes, all rowing in the same direction, we have a likelihood of getting there at some point. But if we're all moving in different places, we can't. And we have lots of good discussion, I think, in the earlier panel about ways in which both the marketplace is aligning and states, as active purchasers, are aligning their delivery system and payment reform efforts across payers. Just gave two examples here. We have Massachusetts, who has passed law that requires the Medicaid program to shift at least 80% of enrollees into value-based purchasing. We'll ask our Massachusetts friends how that's going and what their definition is. It's a work in progress, as it is in all the states. Arkansas is moving a multi-payer bundled payment. So it's bundling payments, but not just in the Medicaid program. It's sitting down with its commercial payers. It's sitting down with the Medicare program and saying, we might not pay exactly the same, but maybe we should bundle the same, or at least be intentional when we change the way in which we're bundling, so that, again, we can be rowing in the same direction as we try and align incentives to deliver better and more cost-effective care. So where is New Hampshire in terms of trying to move forward? You are all much more experts on this than I, but looking at it, you like other states have we have challenges as we go forward. Right now, our healthcare delivery system, and I'm not talking about Medicaid, I'm talking about writ large, our delivery system on healthcare. There's little integration. There's insufficient capacity for treatment of mental health and substance use disorders. We had the governor certainly talk about that eloquently. We have little experience in population health. We know we shouldn't be just a sick care system. We know we want to help people be healthier in their communities. We don't have a lot of experience with that. We have disparities in access across the state, right? Different parts of the state. We have a state with urban areas and rural areas and different systems of delivery of care. We have higher rates in New Hampshire of ER use than the nation as a whole, I saw. And at least one commenter, and I've quoted them, so I'm not speaking from my own opinion, is not yet a shared sense, a shared understanding of what transformation would look like. We know we want to get there, not necessarily a shared vision. I'd like to hear whether you all think that that's right. But also New Hampshire has incredible assets. You score better than average on almost every health indicator. You are a much healthier state than the nation as a whole, and certain states in particular. As we talked about before, you have lower rates of uninsurance, higher rates of employer-based coverage, and so getting to that near universal coverage in New Hampshire is easier lift than many states face. You've got lots of initiatives. You may not yet feel like you have a common vision of where you're all going, but there's lots of things going on. Your SIM grant, duals, lots of efforts going on around the state, interesting things to draw on in the community and statewide. Your all-payer database, hopefully it survives court challenge, really helps you with your data analytics to figure out what's happening now and where you want to go, and whatever levers you're going to pull and push, they're successfully getting you where you want to go, and higher than average adoption of electronic health records. So those are just some of the assets that you have in New Hampshire as you want to move forward. You are also not out of line if you look back at the Medicaid program with where other states are spending. That may not be where you want to be, but you're not out of line except for the elderly. And so while we focus a lot on acute care changes in our acute care delivery system, I also want to underscore the importance of remembering the importance of long-term services and supports. Medicaid is the payer. Medicare doesn't pay. It's for very short-term stays. Very few people have commercial insurance for long-term care. Medicaid is the payer. And we've been making strides in New Hampshire in terms of building a stronger home and community-based care system for long-term services and supports. But my guess is your higher than average expenditures for the elderly has to do with institutional care. So the great news is that you're recognizing some of the challenges, and the governor's statement certainly is a testament to recognizing it at the highest levels of government. We're particularly focused on the need to build the capacity on behavioral health and care for people with substance use disorders. You need to grow capacity. You need to be able to do better integration. These, again, are not unique problems. They're not easy problems to solve, but the good news is that you've recognized them and you've got a waiver pending before the federal government that would help you bring in some additional federal dollars, but just as importantly, she would say, if I were sitting at CMS, is the plans that you have to really think carefully about building that regional-based system and building that interface between physical health and behavioral health in a way that really our systems have grown up in very different trajectories, and it makes it very hard. So I'm going to close now, and hopefully having left you with a sense of all the road that we've traveled so far, but also the excitement of what's ahead, and to again compliment all of you on the steps that you have taken to get to where you are now, the things that you're all thinking about as you're moving forward, and for having such a beautiful state. So thank you. I think we have time for questions. Really? Oh, okay.
So,
All right.
you want to open up?
Sure. One question or two if you talk fast. I'll talk fast. Oh.
Mike Ettlinger.
Hi. So we were talking about, payment and delivery system reform. There's a lot of inertia in the system. There's a lot of people with vested interest in the current system. On the other hand, ACA has kind of created a lot of energy about doing those kinds of reforms. I wonder if you could talk a little bit about kind of what incentives there are to actually keep the momentum going on this, balanced against the inertia and the interest to keep it the same.
So I am known sometimes for being a Pollyanna, but I will say I don't see the inertia right now. There's vested interests. Everybody has vested interests. I have vested interests. We all have vested interests, and we all want to protect and see those interests further. But I think change is so apparent and so much happening. And from the vantage point of sitting at Manette, where I'm not just looking at the Medicaid world, but really working with a diverse array of clients, there's movement everywhere. And whether it'll all be the right movement, and whether some of it's defensive movement as opposed to, really trying to move ahead. But I do think that what there isn't is inertia. And so our challenge is to capture that energy and to make sure that we're being as smart as we can and being as aligned as we can, because I really think there's so much bang for the buck through alignment. That's it.
Thank you so
Okay,
much.
thank you.